Hello, everyone, and welcome to TMA's Ask the Doc webinar series. We are honored to have Dr. Julie Paik with us this month to answer our questions. I'm going to let her go ahead and tell you a little about herself, although I'm pretty sure you all know her. And then a little bit about her work, and then we'll start taking the questions. You can go ahead and start putting them in the Q&A, and we will get this going. So, Dr. Paik, how are you doing?
Good. I'm sorry I was a little bit rushed home because I just finished clinic, so I apologize for the delay. But yes, my name is Julie Paik, and I'm an adult rheumatologist at Johns Hopkins. I am the co-director of the Johns Hopkins Myositis Center, and I'm also an associate professor of medicine. My gosh, I was thinking about, someone asked me this today in clinic, a patient who just came from Connecticut to see me this afternoon, how long I've been here. And I was like, oh, I came to Hopkins in 2010 and I did my training and I joined the faculty. So I've been here for 13 years. That's crazy.
Oh, wow.
Yeah.
Well, that's absolutely wonderful. And we appreciate everything you do. And you're a member of our medical advisory board, and you speak at our conferences and panels, and you're just the all-around go-to person. So questions haven't started coming in yet, but why don't you tell me what are some of the common ones you see when you get a new patient?
Yes, I think the most common is, do I really have myositis first? Or do I have something else? And if I do have myositis, what type of myositis do I have? And I feel like a lot of my patients are so well read, and there's so much out there, especially on a TMA website. They've already sometimes even gone through it, and they have all these good questions. And then, they always ask about what's the screening and management and treatments can you offer me? Yeah.
Okay, so let's go through that. Someone's just got the diagnosis, which means that they've already been through a battery of tests, right? Can you talk about that for those in the audience that maybe have not been diagnosed but have a feeling?
Yes. So I think the most common, I always say there's like 6 diagnostic tools in our diagnostic toolbox. One is the pattern of the weakness, because if it's more proximal, like in the shoulder girdles and the hip girdles, we're thinking more like polymyositis, dermatomyositis, immune-mediated necrotizing myositis. And then if it's proximal and distal, like in the fingers, and you're dropping things, or they have problems with gripping, then I'm thinking that combination of proximal and distal weakness usually indicates inclusion body myositis, or something that I was thinking about in the myositis realm. So the pattern of weakness, number one, is very important. So the exam of the physician is important. And then the second would be like how high your muscle enzymes are. So the classic 2 muscle enzymes we check are the creatine kinase and the aldolase. And then third would be some of the more I guess that's a little more objective than like a physician pushing down on your muscles, would be the EMG nerve conduction study, which is electromyography and nerve conduction study. And that tells us, is it an intrinsic muscle problem, or is it an intrinsic nerve problem, or is it both? And then there's a muscle MRI, which is the 4th one, to look for a picture on imaging of muscle inflammation, or is there a damage because you've had the disease for a long time and nobody diagnosed you for a long time. So that we look for in one of the sequences. And then 5th is muscle biopsy. That's not always needed. For our example, our patients with dermatomyositis who have the classic rash on the face, or the V-neck, or the hands, the goat trins, we don't always have to do a muscle biopsy. But that is a possibility, especially if there's like no rash and we're still trying to figure things out. And then the last but not least, but one of the most important, is the myositis autoantibodies. And that is very helpful as a diagnostic tool and for prognosis. But you have to be very careful about interpreting it, because without any clinical manifestations, and you have a positive myositis autoantibody, like you have to be 100% sure that that really matches that clinical presentation. Just because you have a positive autoantibody doesn't mean you have myositis. You definitely want to make sure. Yeah.
Okay, well, the questions have started to come in. So somebody is asking, I will be having right and left knee replacements and was wondering if you could speak about that in relation to recovering time. My legs are my biggest issue with my IBM. I plan on robotic surgery.
Okay. That's a tough question, I think, but it's an important one. Tough meaning, I hope you're not doing both at the same time with your, IBM. Because when you have knee surgery, you'll be immobilized, and they do actually put you in physical therapy pretty quickly. But it prevents you from doing the important exercise that is needed for our patients with inclusion body myositis. So in terms of recovery time, I think usually orthopedic surgeons will say about 6 weeks with physical therapy. I anticipate, depending on the degree of weakness you have from the IBM, it could be a little bit longer, like 12 weeks. But I don't think, if you have already built up a lot of reserve with your muscle strength, it probably won't be as long as I think it could be. So I think I would say 6 to 12 weeks. Yeah.
Okay, that sounds good. My husband has dermatomyositis for 15 years and is malnutritioned and is extremely weak. And the IVIG stopped working, and also Rituxan is not working. What should he do? Because we seem to have a very hard time finding a doctor. And of course, we know without seeing the patient, you can't really tell them exactly what to do. But do you have any thoughts about pointing her in the right direction?
Yes. Yeah, that's so if you have disease, so it looks like there's malnutrition because the GI, the gut is involved, maybe. I'm not sure. So it depends. If someone has a lot of malnutrition, I would always think about an overlap myositis. And the reason is that GI dysmotility in of itself is very rare in myositis. The only time that you would see that happen would be if you actually had skeletal muscle that was inflamed in some part of the GI tract. So where is the skeletal muscle in the GI tract? The only place is in the muscles where you chew, in the oral pharynx, and then also the distal part, or the latter half, lower third of the esophagus, which is the tube that where the food goes down. And so, and those are small areas. So if that was already treated, but his gut is still not working, then I would think it's not a skeletal muscle problem, but a motility problem. And then you have to figure out why there is a motility problem, and then use medications to treat that. That's why I think why, the IVIG stopped working. It might not be because that there's actually skeletal muscle involvement in the gut, but it's a different problem. So a motility workup would be probably necessary. Yeah.
Okay, we also have some questions that have come into the chat, which is perfectly fine, but it is helpful if you actually put them in the Q&A box, which that icon is right to the left of the chat. I have refractory cutaneous DM, failed most meds, including IVIG, have some muscle, but mainly skin disease, SAE antibody. Rituximab does clear the muscle and swallowing, but the skin is stubborn. Xeljanz, I tried my best, Dr.
Yeah.
Paik. Helped
But
my
that's right,
skin.
though. You said it right.
It helped my skin for about 8 months, with exception of hands and scalp. But because of rituximab, I had to quit Xeljanz as I was told I would be too suppressed. I'm not quite sure
Okay.
what the question is.
Yeah. So we actually led the proof of concept trial in dermatomyositis at our Hopkins Myositis Center. And I always tell the story, it was my patient who inspired me to propose this study to Pfizer, and they funded it. So I think Xeljanz works beautifully in the skin, and you are correct. You really should, your doctor's correct. You shouldn't combine Xeljanz and rituximab. We get very nervous about the immunosuppression, but what if the Xeljanz works so well, then you can combine Xeljanz with methotrexate, and it works really well. And there's a lot of data in patients, even in juvenile dermatomyositis, where the skin is awful, where it works beautifully in combination. And right now we have a phase 3 multi-center international trial that uses the same type of medication as Xeljanz, and we're recruiting right now. So if you're really interested, you please reach out. Where a patient would be giving a similar medication as Xeljanz, but it's actually stronger, and they are allowing background medication. So let's say if you're on methotrexate or Cellcept or Cellcept or mycophenolate or azathioprine, they would add the Xeljanz equivalents to it. So that's totally safe. But rituximab and Xeljanz is a big no-no. Yeah.
Okay. Is it normal to have gastrointestinal swings associated with IBM, such as diarrhea to constipation?
GI swings. So the IBM also shouldn't affect the motility issue that I was talking about. I mean, there are some patients who may get colitis, because if you have one autoimmune disease, it's not uncommon our patients will have a second. So I think if you are having a lot of like alternating constipation to diarrhea, it would be important, to see a GI specialist and get a biopsy, like a colonoscopy, or have them take a look to see what's going on. That because the GI swings is a little bit atypical. So you want to make sure there's nothing else going on and make sure it's not being missed.
Okay. Dr. Paik, do you mind if I take a live question from someone who raised their hand just in case they have a hard time typing?
Yeah.
Okay. I am going to attempt to do this. Okay, Rebecca, you had your hand raised. I'm not sure if that was your computer hand raised. I don't know if that was an accident or if you had a question, but if you have a question, you can go ahead. Your full name is on the screen, and this is recorded and going to be on YouTube. So, but we're also all friends here. So go ahead, Rebecca. Okay, she might not have had a question. All right, how do I lower the hand? No permission to talk. There we go. All right. So if anyone is having a hard time typing in their question, you can go to down there in your toolbar. There is an icon with a little hand. It says raised hand. And I will call on you if you need that assistance. Okay, so blast from the past. We've got somebody in the Q&A who was a patient of yours in 2019.
Oh, I remember.
Sent down,
hello.
Right. It almost seems like this is your life, right? Behind the black screen, we have somebody who sent down from New York for emergency treatment. And they are just so excited to see you. You saved their life. They're now in remission, and they would love to hear your opinion regarding COVID vaccines and flares, prednisone tapers, and how long one can receive Rituxan treatment. So, it's a 4-parter, right? She wants
I remember,
to know
Marissa. It's so nice to hear from you through the webinar, but I hope you and your mom are doing well. I remember meeting you both. Well, so great that you're in remission still, and I anticipate it'll continue. So I think the question is COVID vaccines and flares, how long? Okay, so we have some patients who are on rituximab for many, many years. And if you extrapolate from the multiple sclerosis literature, there are people who are on it for even longer than our patients, because rituximab is first line for multiple sclerosis. So I think as long as your doctor is making sure that, your immunoglobulins, the important antibodies to fight infections, are normal, because we have as physicians actually induced what we call hypogammaglobulinemia, which is because the rituximab gets rid of antibodies, it can predispose you to infections, more infections than we want you to have. So I think the longest I've had a patient on rituximab is at least, 3, 5, 7 years, but I've also had colleagues that they've been on it for like 8, 10 years, which I think is a long time. But if you need it and it works, I think it's okay as long as everything is carefully monitored. COVID vaccines and flares, that's an excellent question. So I've been telling my patients, and it's very well established in the literature now, that anytime you get rituximab, after you get rituximab, the vaccines absolutely have no efficacy. So the flu shot, COVID shot, if you got rituximab even last week or 2 weeks ago, don't even bother getting any vaccine after rituximab. So, and this is well known, it's published in the American College of Rheumatology guidelines. So you want to get any of your vaccines like before you get the before you get the rituximab. So you want to wait 6 months after the dose of rituximab and then get the vaccine, wait about 2 to 4 weeks, around 3 to 4 weeks after vaccination, and then get the rituximab. Prednisone tapers, I think it depends on your symptoms. I think if it's mild, you do a quick taper, and hopefully the rituximab will kick in and you don't have to worry about it. But yeah, sometimes people get a little mild flares and I just give them like very quick taper, like within 10 days, if I think it's extremely mild, and that's okay. That's okay. Yeah, I think that's it.
Okay. What advice do you have for long-term patients diagnosed 15 years ago? What can be done to further reduce wasting?
That's, yeah. So when we say wasting, I think maybe you're asking if there is, okay, so if there's damage in the muscles. So a lot of our patients with inclusion body myositis can get wasting of the muscles and atrophy. And then the other form of myositis, type of myositis where you can get this a lot, is in necrotizing myositis, especially SRP and Asian GCR associated, those two autoantibodies. And the most important is really to treat the disease, at least for the necrotizing myositis. There's a lot of interest in treating it more aggressively up front so that the damage will not occur later. In inclusion body myositis, it's a little bit different because we don't have a lot of good treatments, but I'm still hopeful because there is a very exciting clinical trial that we're about to start with Abcuro. The most important is to actually do the exercise and retain mobility. And I think, I've talked to some experts about this, but a combination of a good medication with exercise, I think is going to make the biggest difference for inclusion body myositis. But I know it's very hard, but if you get diagnosed early with IBM, I think getting that exercise program up and running immediately would be the key to prevent the further wasting. Yeah. But even if it's, it's been 15 years, I would still do the exercise because muscle is big. And usually in myositis, it's not the whole muscle that gets involved. Like when you're looking at an MRI, I was like looking at it just like an hour ago with a patient, it's usually patchy, right? So there are muscles that are still normal that if you really exercise, you can build and they'll stay normal. Yeah.
Mm-hmm. What guidance do you give your patients about diet and nutrition?
Oh, yeah, I think there's no good data about this. In rheumatoid arthritis literature, they say the Mediterranean diet is the best. But anecdotally, a lot of my patients will tell me they feel better, even though they don't have a gluten intolerance, like the kind of anti-inflammatory diet. They do it themselves and they actually feel better. And so there is a lot of interest. Actually, this is funny. I got this question I know they're going to start a study. And she did ask me to, talk about it. So I don't know if I could, but I think I can because it's going to be a new study. It's going to be about a diet study, actually, in myositis patients. and it's going to be led by Dr. Lisa Ryder at the NIH. So when I get those details, we'll make sure we're trying to update our Hopkins Myositis website. But we work very closely with other centers, including the NIH. So hopefully that may shed some light in the future. Yeah.
Okay, this person has the NT5C1A antibody. You diagnosed him in 2013. An antibody report 2015 confirmed the diagnosis. And the question is, what is my prognosis in terms of mobility, strength, and overall daily activities?
Right. Oh, 2013. That's a long time. That was so nice to meet you again. So the overall prognosis for IBM, okay, in terms of mobility, strength, so it's a very insidious disease. So it's very gradual kind of weakness. There are a subset of patients when we diagnose them earlier and they have more necrosis or inflammation on biopsy. I have several patients like this where it may happen a little bit faster, like within 3 years, but most of the time, greater majority is a very slow process. And so again, trying to highlight exercise is very important from the beginning. I've had patients where we diagnose them early and the exercise really keeps them, strong, motivated to do a lot of daily activities. But sometimes, towards the end, like, 20 years, 30 years later, you can potentially, it's not uncommon, you may get, dependent on some assistive devices. But there are a lot that can be very helpful. I have a patient who has a scooter, and now he's like, I'm actually more active and he can play with his grandkids and he's very happy. So, I think it's very variable and we're still trying to understand the natural history of the disease. And that's why we are part of a multi-center natural history study that's led by Dr. Tasim Mohedbar from UC Irvine. And we have about 10 patients in that natural history study. So we can give a better answer and be more informed for our patients about what is the long-term prognosis. So hopefully we'll have more data on that. Yeah.
For those with mixed connective tissue disease, is a myositis specialist the best choice to see?
No, that's a good question too. I have a good answer for this because I do have a lot of patients with MCTD. The best person to see depends. I know it's like so it depends on which organ is active. So in mixed connective tissue disease, I've had patients where the lupus is just very active and they have kidney failure. Well, probably the best person to see them is someone who has a lot of lupus experience because lupus is driving the disease. Because remember, mixed connective tissue is that you have features of lupus, little features of RA, rheumatoid arthritis, little features of myositis, and little features of scleroderma. So if your disease, however, is very active in the muscle and you're very weak, then it's better for you to see a myositis specialist. So that's how I would answer the question. Yep.
This person had juvenile dermatomyositis and ended up with a light case of lupus. They've been in remission for 3 decades plus.
Wow.
After menopause, do you have any thoughts of something that could still be a trigger for relapse?
For lupus or dermato? I guess for lupus, I guess, right?
It's not clear.
Yeah. But I could think about some triggers. So in any autoimmune diseases, we tell our patients to avoid live vaccines because that stimulates the immune system. So that goes for lupus or dermatomyositis or any, RA, rheumatoid arthritis, scleroderma, anything like this. Other triggers, what I learned actually from Dr. Vicky Wirth for dermatomyositis, and she was telling us, she's a wonderful dermatomyositis skin specialist. She's a dermatologist and an expert in lupus and all other skin related things because I'm not a dermatologist. But she has published some data about things that other medications or natural supplements that are found in drinks or like health foods. So for example, like elderberry, ashwagandha, she said, I remember, and in any of those kind of immune supplements you have to be careful about. And she distinctly told me that one of her patients like was totally remission. And then when COVID happened, everyone was taking all these like natural supplements that have all of these, you know, immune stimulating things in them, and then got a huge flare of her skin disease. So in lupus, because I work with, you know, in our division, we have all these giants in the field. So Michelle Petrie on her website, and she tells us to all of our lupus patients, but there are several medications, including like echinacea, right? Just like with the dermatomyositis, echinacea. She also says to like avoid garlic and all these other foods and things like that. But definitely anything that could stimulate your immune system. But, you know, like food wise, I would just say like, you know, it's hard to like avoid garlic completely in lupus, I think. It's in everything. So I think it's just in moderation. Yeah. But those are some medications. Yeah.
Okay. This person is excited to see you and meet you virtually. They've read many of your articles. They were diagnosed with anti-synthetase syndrome in 2018 after a month in the hospital with ILD. They are starting to have quite a problem with synovitis and or polyarthritis. The pain can be pretty bad. They tried SSZ, HCQ, meloxicam, acupuncture, over-the-counter supplements with no help. They were on RTX out of the hospital and got off it. It may have helped, they're not sure. Do you have any ideas of a treatment I'm not thinking of? Because they're thinking of trying methotrexate or even tacrolimus. Tacrolimus. But also, feel free to explain any of those acronyms as you're going along, because there may be people that are watching that don't know the alphabet soup of myositis yet.
Yes. So anti-synthetase syndrome is a type of myositis where you get myositis, muscle inflammation and weakness, and interstitial lung disease, so you get lung inflammation. And then you can also get fevers, and arthritis is very common. And that, I think this is why he's mentioning the synovitis and the polyarthritis. You also get Raynaud's. Worst case I've seen is they actually get ulcers and digital gangrene, but he resolved and it was fine. So Raynaud's is something we always ask about. And Raynaud's is it's named after Maurice Raynaud from the 1800s. He noticed that patients, you know, on exposure to cold, their fingers got very white and there's no blood flow. So that's why you can get like finger ulcers at the tips of your fingers. And then what else? And then of course you have to have a positive blood test for an anti, like JO1 or PL7, and that's on the myositis panel that your doctor can order. So in the past it was thought, and a mechanic's hand. So you can get like these very dry, cracked fingertips, and usually it's on the radial aspect, so like meaning on this side of the finger, not like on the palms or something like this, or on the nails. Okay, so so this is interesting because it's pretty common in the world of anti-synthetase syndrome that there's 3 key features, although I told you many more of anti-synthetase. It's the myositis, ILD, lung disease, and arthritis, myositis, ILD, and arthritis. Those are the key triad, we say, of anti-synthetase syndrome. And the best medication really is, if you are saying, I don't know, it says, wait, PS on MMF for lungs and they're stable. So it depends on how stable the lungs are. If your forced vital capacity, like your lung numbers are really good, then I think it would be best to add, this is also without, you know, seeing all your numbers and examining you and things like this. But if you've tried, you know, sulfasalazine, which is a medication for RA, rheumatoid arthritis, or hydroxychloroquine, which is good for the arthritis, and it hasn't helped, usually the next step would be methotrexate. However, methotrexate has a theoretical risk of causing some scarring in the bottom of the lungs. So you have to be certain that the lung function is very stable before you decide to use methotrexate. So usually what I do in this situation is if your lung disease was bad enough that you need the mycophenolate, then I would layer on rituximab. So if you only got it once, I'm not sure how many times you got it, it's usually not enough to just get it once. My experience anecdotally has been over the 13 years is that one cycle, which is like day 1 and day 15 of rituximab, is maybe will get you like 20%. If I do get 20% improvement, that's great. But you're gonna need several cycles, like 3 or 4 cycles even, for the joints to really calm down. If the lungs are not affected, you can try to switch off to methotrexate, but again, there's that theoretical risk. Tacrolimus is good for lungs, but it's not really great for joints at all. So that's why I think using rituximab would be the best, since the MMF sounds like it really has controlled your lungs very well. Yeah.
This next question comes from someone who is 83. They were diagnosed 12 years ago with dermatomyositis. They take Imuran. They also have lipoid pneumonia and type 1 diabetes and celiac. They ride a bike for exercise most every day, but my legs are getting progressively weaker. What would you suggest?
Oh, okay. Sorry, I lost the question again. Okay, here it is. I think if it's getting weaker, you want to figure out why it's weaker. We don't want to just assume that it's all from the dermatomyositis. And so a few tests that your doctor can do, your doctor can order for you, is checking the muscle enzymes, the creatine kinase, because if that's high, then maybe your dermatomyositis, even though it's been quiet for 12 years with the Imuran, maybe it's flaring up again. And in order to confirm that, you can also do a muscle MRI to see if there's inflammation, or you can do the EMG to see if maybe this weakness is not actually from the muscles, but it's from the spine, like a nerve problem. And the nerve is not properly communicating to the muscle because of compression in the spine. And that's why you're actually getting weaker in the legs. And in that case, the next step after that would maybe even to do an MRI of the spine to see if there's any what we call like spondylosis or spinal stenosis, where the vertebrae on top of each other, and then it compresses the nerve, and it can give you weakness in the legs also. So I would definitely, make sure there's no flare of the dermatomyositis, but also there's nothing else that's contributing to the weakness. Yeah.
Have you had any success with low-dose naltrexone for dermatomyositis patients?
So I have not used it, but I have colleagues in our center who have used it, and they have said it helps with, kind of fatigue and itching. I know we're talking about myositis today, but there are other disease states where they've done small pilot kind of clinical trials as well. And off the top of my head, I remember because I also do myositis, but I also see a lot of patients with scleroderma, and they've seen some improvement in skin itching as well. So I think I personally haven't prescribed it, but I'm not against it if there's nothing else that's helping. Yeah.
Okay, this next one is involved, but I do feel that it will apply to more than just this one person asking. So they were diagnosed with polymyositis following a muscle biopsy and other tests. Their muscle biopsy could not rule out IBM, though. Their doctor started IVIG in late September, but to date, they've had minimal improvement. Muscle enzymes are increasing, although not horribly high. No previous response to azathioprine and minimal response to prednisone. My muscle weakness is now both proximal and distal. And my IBM antibody came back positive for the second time in 6 months. Their myositis panel had been negative. Sought out second opinions to see if they can determine if I have IBM versus PM. My question is, my doctors want to get more aggressive with treatment, including Rituxan, continued IVIG, prednisone, even though I can only tolerate 50 milligrams, and Cellcept. I'm concerned because my understanding is that all this treatment can actually accelerate IBM. Should I be cautious and hold treatment until the second opinion doctors complete their workup, or proceed to see if I get any relief?
Okay. So I think there are a few things that are important here. The muscle biopsy could not rule out IBM. So I think that's important to really have, I don't know where you're going for the second opinion, but a good place where you can trust the neuromuscular pathologist to look at the muscle biopsy again, because it's important to know that we saw what we saw there. Is it really IBM or not? And if it's not, then what is it? Because um, I'm not sure how old you are, but if you're younger and there is proximal and distal weakness, we want to make sure it's not a genetic muscle disease either. Because we've been, fooled in a sense that, oh, this is myositis, and then actually it ends up being a, muscular dystrophy. And you can get proximal and distal muscle involvement. So it's very important that, because it sounds like the muscle biopsy really could not rule out IBM or something else, it's important to take a really close look at that. If it is truly IBM because the antibody was positive, remember we did do a study, my colleagues did do a study that the IBM antibody is not 100% specific, like some of the lupus antibodies. You can have positive anti-5C1A in even dermatomyositis, lupus. It's rare in those diseases, but it still can be positive. So hence, really making sure that this muscle biopsy is looked at is still the gold standard for IBM. Now, if it is IBM, but the biopsy, let's say, showed a lot of inflammation, and that's why they want you to get this aggressive treatment. So we've always at our Hopkins Myositis Center with my neurology colleagues have noticed that there are patients who actually have this more PM IBM phenotype. And so on biopsy, there are like rimmed vacuoles, but then there's also intense inflammation like polymyositis. And so in those cases, we have treated with immunosuppression to see if we can calm that down. And when we stop the methotrexate or the CellCept or something like this, they get worse. So in those cases, we've kept patients on methotrexate, low dose. And I know there was a question like, would the immunosuppression accelerate IBM? It wouldn't accelerate IBM. It really wouldn't. It just wouldn't help it at all. And you would just get progressively weaker. So yeah, I think it's good to be cautious because we don't know what you have, and the fact that you didn't respond to anything, it could be IBM, or is this some other genetic muscle disease we don't know about in the muscle biopsy? You may need a repeat muscle biopsy too. Yeah.
Okay. I have IBM and take no meds. How do you feel about creatine supplements, and how much do you recommend daily?
Yes. So the creatine supplements is, I think, up to like 1,500 to 2,000 per day that you can take. I think it's totally fine to take, and people put it in like their, health drinks, or smoothies or something like that, because sometimes too many pills. And I think it's totally fine to take. We do recommend our patients with IBM to take it.
Okay, this person was diagnosed with sporadic IBM by their neurologist at Yale after their EMG swallow study, and NT5C1A results came in, even though they are only 30. They have some low-level autonomic and autoimmune-like features and a family history of supposedly DM and SIBM. So they want to look into overlap autoimmune issues and genetic muscle diseases. I've had issues getting rheumatologists to see me because of, you'll have to help me with that.
1 to 80 titer ANA. Yeah.
Okay, go ahead.
Oh, okay. So I think you're quite young, for IBM, but I have had some younger patients. I think the youngest I've had, he was in his late 30s. I've had a woman in late 30s. I'm not sure why we're seeing it. Wait, let me just wait, I just want to look at the question because I don't know.
Did I not? I'm sorry if I.
Oh, it's okay. It's okay. I just went to the answer thing. Okay.
Yes. Okay.
Okay, I'm sorry. So I hope you had a muscle biopsy to make sure that that's what you have. because it's still the gold standard, and I don't know how high the NT5C1A result was. But if everything makes sense, then, you know, I trust that they make the right diagnosis. So if you want to look into overlap autoimmune diseases, so yes, I do. I remember I've had several. We were trying to write it up where I have patients with IBM and lupus together. I have another colleague with the same, and so we had like 4 patients together, and so we were going to write up this case series because people think, oh, IBM, you know, it's a degenerative muscle disease, but it's still autoimmune. We still don't know why it's happening. So you can have 2 autoimmune diseases with the overlap. Anyway, so I think, you know, if you have an ANA of 1 to 80, that's actually higher than an ANA of 1 to 40. Like, I think most rheumatologists are like, oh, 1 to 40, that's probably nothing. But 1 to 80 is slightly better. It is true that a lot of rheumatologists won't get as excited, maybe, potentially. The word excited being used loosely, that unless you have a positive ANA of like 320, 640, things like this. But I think in your case, I'm surprised you haven't been able to see a rheumatologist. So hopefully you'll be able to find someone. I think if you're at Yale, there's a good rheumatology group, including there's somebody, shoot, I forgot her name, but she does mostly Monique Hinchcliffe. But she does mostly scleroderma, but that's oh, and then Evelyn Shea. I think she's also a rheumatologist there too. But if you can't, then I would look at other places and we'd be happy to see you as well. Yeah.
Do you know of a pill that DM patients can take to prevent sunburn?
Oh, that would be amazing. I would make a lot of money off of that. No, I don't. I wish that's a great idea. That would be amazing. No, I wish we had something like this. We just say wear like the wide brim hat and the SPF. But you know what? Like my friend was showing me how like there's these things you can like actually like put on your skin that has SPF on it, and it just like disappears. It's like a sticker. And then people cover their face, like, you know, make sure that they don't get sunburn on the face and things. But no, I don't know of a pill, unfortunately. That would be amazing.
My daughter has anti-synthetase syndrome. She lost 40 pounds quickly and they were alarmed. After much testing, she was diagnosed with ILD 3 years ago. Her fingers show signs of clubbing. Her lungs were stable for 2 years. Now her CAT scan showed more scarring. She developed a dry cough and is now on Rituxan. She has had 2 treatments. She is also on a lot of seizure meds and mycophenolate and 5 milligrams of prednisone daily. Their daughter is nonverbal, so they don't really know how she is feeling. Do you have any recommendations for other tests because she is very frail?
Yes. So for the lung disease, so we always say this is really standard of care for our patients with myositis and lung disease. We monitor your lung function every 3 to 4 months once you start treatment. So if she started mycophenolate, I'm hoping that there's a baseline breathing function test or pulmonary function test, and then 3 to 4 months later, like we're checking and making sure things are improving. And then, you know, the rituximab also works very well for the lung disease and the muscle disease and the joints. But again, like I said before, you do need more than just 1 cycle. You probably need at least 2, 3, 4 cycles to get some significant benefit. Any other recommendations for other tests? Because she's very frail. I think if she's, when you say frail, you know, if she's still having a lot of weakness, I think the muscle MRI can tell us if she had a very aggressive myositis with the muscle enzymes being really high, then you want to look, was there any damage to her muscles? And the MRI can show you on a picture if there's actually any fatty atrophy or replacement of the muscle that makes her really frail and unable to, you know, engage in more muscle activities that require more muscles, in which case then you really want to push the physical therapy. The other thing is, if she, even though she's nonverbal, PT and also pulmonary rehab, especially because she has interstitial lung disease, would be really helpful. They get you on the treadmill, they're monitoring your oxygen. And I recommend it for all of my patients with lung disease, with myositis associated lung disease. And they really make you work to use your lungs. And so I think that's also very helpful. Yep.
This person's not able to walk upright any longer because it hurts too much and it affects his breathing very badly. What could be causing that to happen? And then also they had a second question about, does IVIG have a side effect that causes bladder or kidney problems because it seems to occur after he gets these injections?
So whenever pain is involved, it's difficult. Myositis, so the actual muscle tissue doesn't have a lot of nerve fibers, but if there's a lot of fasciitis, which is the kind of the muscle, the encasing around the muscle, right? When I always tell this story, like if you buy chicken at the market, there's like muscle, and then there's that thin layer over the chicken or the red beef. That's the fascia. So if there's a lot of fasciitis or inflammation there that could cause a lot of pain, then it may, certainly make it difficult for him to walk. That could be one reason. Or if somebody has a lot of pain from the back, the lower back, that can also cause a lot of pain. So then you would need to do imaging of the spine. So it's kind of hard to say. And then there's also something called small fiber neuropathy. So it usually happens a lot in Sjogren's syndrome. But let's say they do the EMG because he's in so much pain and they want to see, oh, is it really coming from the back? Is that the nerves in the spine are all healthy or not? Then they will do skin biopsy to see if the nerve fibers in the skin are abnormal or there's affected. And they usually do, I used to do this for a research study, but this is standard of care now. If they're looking for, small fiber neuropathy for clinical purposes, you just biopsy. I'm looking at my leg, but it's like the one part of the, like 3 different parts of the leg, basically, to see. And if that's abnormal, then that would be small fiber neuropathy, which would not come up because these are small nerve fibers, which would not come up on an EMG. So that could cause a lot of pain sometimes, neuropathic pain. So does IVIG have a side that causes bladder or kidney problems? So IVIG can cause kidney problems. So it's important to be well hydrated before you get it. And if it keeps causing kidney problems, then we actually stop it. It shouldn't cause bladder problems, though, to my knowledge. Yeah.
How often do you see dermatomyositis patients with low to normal CK and a multi-year long insidious onset?
So patients with dermatomyositis can have low to normal CK because remember the spectrum of dermatomyositis is you have amyopathic, meaning you have no muscle involvement, but just skin. Hypomyopathic dermatomyositis means you're very strong in exam, but if I really took a deeper dive and did a muscle MRI or a biopsy, then there's clear evidence of muscle inflammation, but you're still very strong. And then the full-blown kind of definitive dermatomyositis is you have skin and moderate to severe weakness that gives you proximal weakness. So we do see a lot of patients who have low to normal CK and they have more skin disease. So we call them like skin predominant or amyopathic, hypomyopathic dermatomyositis. Multi-year long insidious onset. I think this could happen if you have mild skin, and it's only on the periungual area. And you're like, oh, your doctor's like, it's just a little sunburn or something like this. And then you just put some, steroid ointment on it and it might just go away. And then it comes back later. It's more like spread. So I do feel like that could happen over years and you're just putting like topical steroids on it and it gets better. I've seen that happen where the skin is like active for some time, for years, kind of coming and going. And then later you get more severe disease. Yeah. But I don't know the exact percentage of that, but I've seen it. Yeah.
What does a dermatomyositis flare look like?
So it depends on which organs are involved. So if with dermatomyositis, you have skin predominant disease, then the skin rash can be extremely involved. So the severe case would be, head to toe redness, which we call erythroderma, and almost looking like, I've had several patients like this. I can spot them from they're waiting in the living room. I mean, not the living room, the waiting room, and they're just fully red, like a beet, right? And it really looks like their whole body is sunburned, but it's like that all the time. So that could be kind of more the severe redness. Most of the time, though, it'll be in the areas that are classically distributed, like over the knuckles or the V-neck, or like the shawl sign we say, or the sides of the thigh muscles, which is the Holster sign. Other more severe skin flares, I've seen ulcers, punched out ulcers that could sometimes get infected going to the bone, and you need surgery because it gets infected. Ulcers like opening up in the scalp. I mean, it's a very big range, I think, for the flare, depending on the skin can get very severe. People think, oh, this skin is just mild. I think most people are, but there are a subset of patients where it's very severe and get infected. And then the muscle, you will get weakness, right? If it's, if the muscle is really active, or you can have both at the same time. If you have dermatomyositis with lung disease, you can get extremely short of breath. Like I was just on call in the main hospital for 2 weeks, and we had a patient like this, short of breath for, 6 months, but then acutely, and they were on treatment, but acutely they got really ill. And they're having a lung flare of their dermatomyositis. And then we have to give them high dose steroids, and they were very close to being intubated because the flare can be really bad where the lung gets really inflamed. So it depends on like which which organ is involved from the beginning. Yeah.
I'm trying to time the flu, COVID, and RSV vaccines due to rituximab infusions, which I had in June. Tomorrow, I'm having the CD19 and CD20 blood test to see if my B cells are repopulating. I had rituximab infusions in 2020, and the benefit lasted almost 2 years before muscle weakness came back. So if my B cells are still depleted 5 months post-June infusions, are the vaccines a waste at this time?
Yeah. So she's trying to time it. So no, even if the B cells are depleted, I think you'll still have some benefit, I would say. I don't know if we know the full answer, because you're not, when you get the vaccine response, it's not just solely on B cells. The T cells are also very important for vaccine response. So I would say that tomorrow I'm having this, I would still get the vaccines if you can before your next round of the rituximab infusions, at least 2 to 4 weeks before the second round, I guess in December, that you would be getting the rituximab. But you really need to wait at least 6 months. I would still try to get it. So I can give you some more specific details. So when the COVID vaccine started to come out, I worked with the transplant team here. And we looked at all patients who received transplants and autoimmune diseases, who got the COVID vaccine and got rituximab. And none of the patients had absolutely any protection, which was really sad. And so that's why there was some high death rates in patients who got real COVID before the vaccine came out, and they were on rituximab. And all their physicians, oh yeah, just get the vaccine, it'll be fine. No, like the vaccine had no efficacy. This is also true for Cellcept or mycophenolate. So remember, if anybody on this call is on mycophenolate, you also need to hold, especially for the COVID shot, at least 1 week after your COVID shot. Don't take the mycophenolate for a week, because it does impact your vaccine efficacy. So, but when we looked at the patients, and we published this in Annals of Internal Medicine, when we looked at the patients specifically who received rituximab, there was some response if you waited at least 6 months, but there was a better response if you waited 12 months after your rituximab infusion to get the vaccine. But it seems like you do need to get the rituximab for your disease. So I think I would at least get it to get some benefit. Yeah.
We have one question left. Time for just one more question. I'm felt to have IBM on the basis of anti-C1A 3 years ago with symptoms for 10 years. Biopsy positive for myositis without inclusion bodies seen. CKs routinely around low 200s. Also have wild type amyloidosis and a neuropathy with FGFR3. Any association of IBM with the above?
Yeah, it is a little unusual that they didn't see the inclusion bodies. If it was done at a hospital where they don't read a lot of IBM myositis cases, you may want to have it sent out as a second opinion. Usually it's like $100, like even at Hopkins, if you send it out as a consult to make sure it wasn't read improperly, because it sounds like, you have symptoms for 10 years and the antibody is positive, so you probably definitely have it, but it would be nice to know for sure. Anyway, so that's the first part. The wild type amyloidosis and neuropathy, that's interesting. So we do know that patients with inclusion body myositis can get neuropathies, but not so much amyloidosis. So I would definitely make sure that, there's a full workup for amyloid by your physician. And that would be kind of the neuropathy. Yes, we see it, but not so much the amyloid. So we want to make sure there's no other reason for that and not just attribute it to the IBM association. Yeah.
All right. Well, thank you so much. We really appreciate you taking the time to do our AciDoc webinar. And did you have any last minute words that you wanted to share with our audience?
Yeah, no, I think it's an exciting time for us in myositis. We have a lot of treatments. I feel like finally we are getting this upswing in all the pharmaceutical companies being interested, and this is a lot to do with the TMA's, support to get myositis being recognized in the international medical community and also by the patients and better diagnosis. So I think it's a hopeful time. But you're right, the diagnosis, I know we got all these questions about it. The diagnosis has to be correct. So make sure you self-advocate for yourself and, seek the best care that you can. Yeah.
All right. Well, thank you so much. And to everyone in the audience, thank you for watching. And we look forward to seeing you next month for more webinars. I mean, it's the favorite part, my favorite part of my job, right?
Yeah. Awesome.
Okay. You guys have a good night. Bye-bye.
Bye-bye.